Okay, I'm going to go ahead. It's 12 o'clock, so I'm going to go ahead and get started. Hello and welcome, everyone. Welcome, Oregon and Idaho. We have some Idaho clinics that are attending the webinar today. I'm Rhonda Ann Gerst, the Rural Health Clinic Program Manager at the Oregon Office of Rural Health. Today's webinar is titled Rural Telehealth. What is the impact of RHCs during the public health emergency and beyond? This webinar is hosted by the Oregon Office of Rural Health and presented by Patty Harper of INQUISEEK. Patty will discuss how COVID-19 has changed the way we use telehealth to provide patient care. Patty Harper is CEO of INQUISEEK, a business and healthcare consulting company based in Louisiana. She has over 22 years of healthcare experience in the areas of healthcare finance and reimbursement, health information management, compliance, and practice management. She began her healthcare career as a hospital controller and reimbursement analyst. Patty holds a BS in Health Information Administration from Louisiana Tech University, among many, many other credentials that I'm not listing here to kind of cut it short a little bit. Patty currently serves on the board of NARC and LRHA. Let's see. Before we start, I have a few housekeeping details to cover. This webinar will be recorded. I did send out the slide deck prior to the webinar. I hope you all received it. If not, the webinar and slides will be posted on the Office of Rural Health website within the next couple of days. You are currently muted. Video is also available on this WebEx event. You can either turn it on or turn it off. That's up to you. Anytime during the webinar you have a question, please type it into the Q&A box and I will read your question to Patty. Patty is happy to answer your questions during the webinar at any time. After the webinar, there will be time for questions as well. I will also be sending out a very short survey. Please take time to complete the survey so I can continue to make improvements with webinars. I would also like to send out a thank you to Eric Jordan, who is in the background providing technical support on this webinar. So thank you, Eric. Thank you for attending today's webinar. At this time, I would like to present Patty Harper.
Thank you, Rhonda Ann. Thank you. It's great to be with all of you from Oregon and Idaho today. We're going to talk a little bit about the very things that Rhonda Ann said, but particularly about what the impact to critical access hospitals and RHCs have been during the public health emergency, and what does the future look like for rural telehealth as we move forward. Again, feel free to ask questions as we go along. Okay, I'm having a little trouble advancing my slide. Let's see what the problem is. All right, so as we already know that the Oregon Office of Rural Health is sponsoring this, and these are the things that we're going to look at today. So we're going to talk about what has changed for us as rural providers during COVID as far as telehealth services. I'm going to talk about the challenges that we've had with telehealth during the public health emergency, and we're going to start imagining how this may change the landscape for the future as far as telehealth and rural providers. The first thing I think everybody knows that the public health emergency has been extended. Secretary Azar made that extension on July the 25th. So at least until the end of October, we will still be in a public health emergency, and all of the blanket waivers, those that affect telehealth, will be in effect until the end of November. I think it's very interesting, and we're going to have a couple of soundbite quotes from different people, but the first one is from the director of the Office of Civil Rights. And the quote that, that he has made is that during the public health emergency, we're empowering medical providers to serve patients. So you might ask, why is the Office of Civil Rights concerned about telehealth? And he goes on to say that we're especially concerned about reaching people most at risk, older persons, and people with disabilities. So telehealth is actually a civil rights initiative as well as a healthcare initiative. Here's where we can actually go and see the extension of the public health emergency. This is a little bit old news now since we're about 3 weeks into the extension, but I still am getting questions on a daily basis. Can we still do telehealth? Is the public health emergency still in effect? And the answer is yes. So how exactly has the public health emergency, how has, down here in the South, we're calling it the COVID, like we go to the Walmart and we don't want to get the COVID at the Walmart. So during the public health emergency, during the COVID-19 emergency, how exactly has the way that we provide services with telehealth changed? And for rural health providers, it's been a significant change. So in the very first public health emergency blanket waivers that were issued, it talks about extending Medicare telehealth services. There was a little bit of a confusion at first because they said all rural providers would be able to do telehealth. And then as we knew, there were some obstacles with rural health clinics because we were statutorily excluded from being distant site telehealth providers. And so it took several more weeks for us to get that cleared up and several more weeks to get a reimbursement strategy for it. But the very first blanket waivers were those that expanded the use of telehealth during the COVID emergency. Before we start talking about telehealth a little bit more specifically, I think it's really important to talk about the definitions. So when we talk about originating site, the originating site of telehealth, that is the location of the patient. When we talk about the distant site of telehealth services, that is the location of a provider. And these are very easily confused because sometimes they seem like they should be the other way around. I was on a conference call that we talked about telehealth for over an hour. And then when the minutes to the meeting came out, originating site and distant site had been switched in the meeting minutes. So I just want to make sure we're clear on our definitions as we go forward talking about telehealth. Originating site is the location of the patient. Distant site is the location of the healthcare provider who is rendering the telehealth service. Telehealth services are professional services, so they are services that are typically billed under Medicare Part B, or if our critical access hospital bills professional services under Method 2, then that would be how telehealth services would be billed. Rural health clinics are a little bit different. So rural health clinics before the public health emergency could only be distant site providers. So before the public health emergency, rural health clinics could only host a patient. You know, I got that backwards, didn't I? I told you it was easy to get that backwards. So before the public health emergency, the rural health clinic could only host the patient who was receiving a service from another provider that was somewhere else, like a specialist. So it took some legislative gymnastics to get that changed during the public health emergency. So before the waivers were put in place, the rural health clinic could only charge the originating fee because they could only host the patient. So we've had new billing guidance that had to come out for rural health clinics concerning which codes to use. They actually created a new code for us for rural health clinics to use for telehealth. And so this is all new. It's all new to us. So, and so likewise, the hospital was only able to charge a facility charge for hosting the patient as well. But now under the public health emergency blanket waivers, there's no restriction on the location of either the healthcare professional or the patient. And this will continue through the end of the public health emergency as long as that declaration is in effect. So it gives us quite a bit of leeway. The waivers give us some flexibility, like I said, in the location of originating site and distant site. So where our patient is, where our provider is, we have flexibility that we did not have previously. We also have flexibility with the services, which can be performed as telehealth services. So CMS has come up with an expanded list of services that they will allow to be performed via telehealth. And also, there's some flexibility across the provider types. So provider types which normally would not be reimbursed for telehealth services, there's some flexibility in those provider types. And there is increased or additional reimbursement for some provider types and services. So for example, the fact that rural health clinics can be distance telehealth providers now, there is an added reimbursement that goes along with providing that service. And now non-rural providers can also use telemedicine. So this is something I think that the rural community has been a little bit apprehensive about, wondering if urban providers will now encroach on our rural areas through telemedicine. And even though this is just during the public health emergency, I think it's something that we really have to be careful to be protective of our service areas and make sure that we as rural providers, as critical access hospitals, as rural health clinics, that we are the ones that are reaching out and meeting the needs of our patients and the needs of our communities. Another leeway that we've been given during the public health emergency is that there is no HIPAA enforcement right now pertaining to non-compliant telemedicine methods of communication. So you may have heard that HIPAA has been waived. So that's not entirely true. HIPAA has not been waived. The enforcement has been waived. So we are now able to use communication methods that are non-compliant or normally wouldn't be considered compliant with HIPAA if we're needing to use them during the public health emergency. So this was very important when we very first were trying to transition to telehealth, and rural providers didn't have equipment, we didn't have work processes in place. A lot of people were scrambling. So the Office of Civil Rights said, we won't enforce it if you use a non-compliant method of communication. We also are allowed to use expansion sites during COVID. So whether that is for the way that we provide telehealth services, or it's the way that we separate sick and well patients, now certified facility types like hospitals and rural health clinics are able to expand those sites without having to have those sites separately certified right now. And that's great. So we have a critical access hospital in the South that set up all of their telehealth in one building so that their providers could rotate through that building and not interrupt the way that the clinics were operating otherwise. The public health emergency also has a waiver which lessens our staffing requirements. So our staffing requirements for rural health clinics, as far as the percentage of time that the nurse practitioner or physician assistant needs to be in the clinic, other staffing requirements as far as direct versus general oversight for some of the outpatient departments of the hospital have been loosened. So the purpose of the public health waivers, the blanket waivers, is we're just all trying to take care of patients. We're still trying to take care of patients. And so we're having to color outside the lines a little bit. And so that's why we see some of these other blanket waivers that bend the rules a little bit. The other thing that's really important to understand is that we can use telemedicine, telehealth during the COVID-19 emergency for both COVID-related and non-COVID-related services. So this has been extremely important because in our communities, our patients that have chronic care issues that need regular ongoing treatment for chronic conditions, or maybe our children who need to stay up on their immunizations, or they need to stay up on their well child screenings. You know, we're seeing where people are not wanting to come into the clinic, get out and about in their community because they're concerned about exposure to the virus. So we can use telehealth for both COVID-related screening of patients to see if they need to be tested for COVID, but we also can use them for non-COVID related patient services, to make sure that we're keeping our patients on track with their preventive services and we're keeping them healthy during this vulnerable time. If you want to see a complete list of everything that can be done via telehealth, CMS has published this list. The list is quite extensive. You can download it as a zip file. And we're going to look at a few examples of some of the codes that are included in that. For the most part, it includes evaluation and management services. It includes other evaluation and therapeutic services, preventive services, and general medical services. So the next two slides are just going to be an example of some of the things that are on there. So some of the CPT codes already were approved for telehealth for Part B providers. And then you can see that hospital observation care, inpatient care, those have temporarily been added only during the public health emergency. So the complete list is available. It's in an Excel sheet. And then we can also see that our preventive services, which can be performed by telehealth also. So we've had a lot of questions about how do we do an annual wellness visit via telehealth? How do we document a telehealth visit? If we can't take the patient's vitals, what does our clinical documentation need to reflect? But just be aware that these preventive services can be performed by telehealth. For our rural health clinics, we have a few challenges when we're doing preventive services because we are having to report everything under G2025. And so the patient nor the provider is getting credit for actually performing that preventive service. And so that's a problem that CMS is aware of. And we have a few suggestions on how you can go about that. Do we have any questions on what services can be performed via telehealth?
I don't see any questions in the Q&A right now.
Okay, all right. We have a shy group or everybody is eating their lunch.
Yes, they are a shy group.
Okay, all right. Okay, so we're going to talk a little bit more about HIPAA. I mentioned that the enforcement of HIPAA has been, I kind of like to say that the Office of Civil Rights is going to turn a blind eye to HIPAA requirements for compliant communication during the public health emergency. So we are being told it's fine if we want to use FaceTime, if we want to use Skype, if we want to use Messenger, those are fine. That normally would not be a HIPAA compliant way to have an audio-visual exchange with our patient. But since we're in the COVID emergency, they're turning a blind eye to that. However, we're reminded that we can't use anything that is public facing. So although I could use FaceTime or I could use Messenger, I could not use Facebook Live. And you'll have to ask somebody younger than me what Twitch and TikTok are. Not really sure, but we can't use those either. And so this waiver or this turning a blind eye to HIPAA compliance is only during the public health emergency. Now, as much as we can, we still need to be HIPAA compliant. And we're going to talk about how we need to let the patient know if we're not using a compliant means of communication. And we also have to get consent from that patient. So the patient needs to know that this would normally not be a HIPAA compliant way to have a healthcare service provided. And there's a little bit of duplication on this slide. So we also, want to, again, make sure that we notify that patient that the application that we're using has some privacy risk and get permission from them and document that we did make them aware of that fact. There are some vendors who do have HIPAA compliant communication products. If you are entering into an agreement with a vendor who has a HIPAA compliant product, then you're going to also want to have a business associate agreement with that vendor. Now, the Office of Civil Rights is very clear that although you need a BAA when you contract with these vendors. The Office of Civil Rights has not actually evaluated those business associate agreements or evaluated that product to see if the business associate agreement is valid. So you're going to want to do a little bit of due diligence on that yourself. But these are some of the more common HIPAA compliant applications. I know with some of the grant money for equipment that has been made available, people are scrambling around trying to buy things. And so, you just want to do your homework and make sure that whichever product you choose or whichever product interfaces with your EHR, that it is HIPAA compliant going forward. You don't want to invest money in something that you're not going to be able to use after the public health emergency is over. So what are the challenges that we have with providing telehealth during the public health emergency? So yesterday I did a phone interview with a Louisiana State University grad student who was trying to capture the challenges of COVID for rural providers. And so I remember that I told her we're new to telehealth for the large part in rural. So the biggest challenge was just being able to ramp up and know how to integrate telehealth into the way that we practice medicine in rural. And I think we're all pretty convinced that there's not going to be much going backwards from this, that we have all realized the advantages of telehealth. We kind of needed that little shove because I've been working with rural providers about 12 years now, and I don't go into a critical access hospital that does not have a graveyard of out-of-date, antiquated telehealth equipment that they got a grant for somewhere, but they never were able to fully implement that technology. So some of the challenges that we have are we still have areas in rural that do not have access to high-speed internet. So connectivity is still a problem in a lot of rural areas. Dependable, consistent internet service is not available. We did a WebEx this morning with some rural providers, and we had some problems because they did not have a good, steady internet connection. We also still have limited access to smartphones and smart devices. And this is particularly with our patient population in rural. They may not have a computer at home. They may not have a smart device that enables, they still may have a flip phone. So they have technology limitations on the patient side. I know we've had some communities where they have created places that the patients can go within their community where a smart device will be available for them to have their telehealth visit with their provider. Even though we have the public health emergency blanket waivers that extend our scope of practice a little bit from state to state, we still have credentialing and licensing issues. So we had a question come up on the NARC listserv earlier this week about a Texas physician who had a patient who was in South Carolina. Can we provide telehealth that far away? And some states do have requirements that you be licensed in the state where the patient is. Many state medical boards have also waived that during the public health emergency, but it's something that you want to be sure that you know, particularly if you have patients that are across state lines. We still have reimbursement issues with telehealth. So for rural health clinics, this is a big issue because the payment that we're going to get for G2025 for all of the telehealth services that fall under that umbrella is a fee-for-service payment. It is not our all-inclusive rate. And so we still have reimbursement issues in the fact that not all providers are being equitable. It's not equitable reimbursement across all provider types. And then we always have questions about sustainability. Is this something we're going to be able to continue to do going forward after the public health emergency? Connected to the licensing issues, we also have concerns about malpractice. So a lot of questions from physicians and non-physician providers does my malpractice cover the services that I provide via technology? And so that's a lot of questions that have to be answered. And we still have transportation issues in rural, even if we're trying to get those rural providers to a town hall or a library or a church where perhaps there can be a telehealth station set up for them if they don't have a personal device. We still have issues with interoperability. We've been trying to do this electronic health record thing since 1998, I think. We still do not have, widespread interoperability across the country, which was, the information highway goal was for me to be able to be in California and a provider in New York be able to see my EHR. So we're still a long way from that. And when it comes to telehealth, and with us having to learn to do this on the fly, a lot of our EHRs did not have telehealth modules. A lot of our providers were having to go back to using a paper note and their iPad. And so, how are we accessing that patient's record to get that history? How are we getting everything in one place as far as interoperability and access? The other thing is, and this is patients and providers, have a mistrust of technology. So we have some of our patients, or maybe our elderly patients, or our patients that haven't been exposed to technology that are mistrusting of having that visit on their phone or that visit on their computer. But we also have providers, particularly older providers, who also mistrust technology. I had a doctor about my age tell me, how can I truly examine somebody if I can't lay my hands on them? And so those are some barriers of getting comfortable with technology, getting comfortable with providing healthcare in a different way. And that leads into probably our last obstacle, and that is just we don't have provider buy-in for it. Or we don't have enough volumes to sustain it. So I think we all know we're not going backwards from telehealth, but we still have to look at how we're going to overcome these particular barriers. And then we may have internal barriers within our own organizations. So independent rural health clinics are very small organizations. We're able to shift gears and be creative about how to implement telehealth a lot more easily than larger healthcare systems who just weren't nimble enough to make these changes. So if you're part of a larger healthcare system, you know that you have a certain way things have to be done, things have to be approved, and expenditures have to be approved, policies have to be rewritten. So our smaller organizations were a little bit more creative and a little bit quicker coming up with some quick solutions. But those solutions have to be transitioned into things that we can sustain. We also have had system limitations. So I mentioned before that maybe our EHR doesn't have a telehealth module. It didn't have a telehealth module. We saw EHR companies scrambling to create a telehealth module. We created a paper note very early into the public health emergency and offered it for clinics and still can offer it to you if you need an example of what might need to be included in a note. We're going to show that on some slides here in the future. So we didn't even really know how to capture a telehealth module. Was it something that we could do through our EHR? Was it something we could do through our portal? And for often we were having to create that as we went. Technology limitations. What about our providers that weren't working from home? Privacy and security issues with technology. Again, that trust issue. So does our community trust being able to see their provider through telehealth? And do they have the devices and the access to technology that they need? And then we have financial restraints. patient volumes were down, cash flow was down, still is down. We're still hurting. Our rural hospitals are still hurting. The relief money has helped, but it hasn't solved all of our cash flow issues. So could we even invest in what we needed to launch a telehealth program? And then the cost report ramifications, which this is something that you really, before you make a decision on how you're going to spend your relief money, your phase 2 or phase 3 money, you need to talk to your cost report preparer about those ramifications, because some of that money is going to offset your allowable expenses on your cost report and potentially reduce your reimbursement next year. So even though we desperately needed that shot in the arm with that money, it could cause a problem for us down the road. So we're going to talk a little bit about clinical documentation. I know not everybody on the call necessarily is responsible for clinical documentation, but these are things you probably just need to keep in the back of your mind. So we do need to obtain consent to treat. The consent to treat can be obtained by our office staff verbally over the phone when they schedule the telehealth visit. It can also be obtained by the provider before the telehealth visit begins. And we want to document that we did obtain consent. If we have a telehealth visit with a minor, we're going to also want to document who was with that patient for the telehealth visit and what the relationship that person was to the child. We're going to want to document stop and start times. So we're going to actually need to know how long were we on the virtual or the telehealth visit with the patient. And so that may be something that your providers are not necessarily accustomed to doing. The location of the patient and the provider, even though we have flexibility in both the originating and distant site, we still want our clinical documentation to confirm where the patient and the provider were. If we're not able to document vitals, then we have two options. We can collect vitals as part of the history of present illness, or we can document the vitals that we were not able to obtain them. So we can, instead of objectively documenting them as if we were taking them in the office, we can record them subjectively as history of present illness or the review of systems, or we can document that the vitals were not able to be obtained. We can use a paper note, or we can use an EHR template, whatever you have available for you. And we're going to want to document, just like we would in any other note, what our assessment was, what test we ordered, what treatment was ordered for the patient. So did we refer the patient to the emergency room? Did we refer them to a COVID testing center? Did we tell them to come back in the office? And then we're going to want correct ICD-10 coding for the reason of the visit. We're going to look really quickly at that paper note that I was telling you about earlier. So, and it's going to collect as much demographic information as we have about the patient. And if you want to kind of compare what your EHR note looks like to this, then this might be a good comparison. Or if you're creating an EHR template for telehealth, you might want to use this as a guide. So we're going to want to record the patient demographics. We're going to document that we obtained consent, and we're going to document that we let them know if what HIPAA concerns needed to be disclosed about the type of communication we're using. We're going to want to document what type of service that we did, what kind of technology we were using, and we're going to want to document down on the red box on the slide the location of the patient and the location of the provider. Now, this particular note was designed to be used for either a COVID-related service or another acute or chronic condition. So we also have a checkbox for that. So whenever you're having to do a paper note for a provider, the easier that you can make it for them by making it checkboxes is a good way to collect all the necessary elements for the documentation. We're going to want to collect a history of present illness, just as we would do if the patient were in the clinic or in the hospital outpatient department. So we've pre-populated a couple of the signs and symptoms that we might expect to see, particularly those related to COVID. But if that patient is being seen for a chronic condition, we're also going to want to document the status of those chronic conditions. Hypertension is stable, diabetes is worse, back pain is better. So however we want to document those chronic conditions, that is part of our history of present illness. We've added a few more check boxes to make sure that their problem list was reviewed, their medications were reviewed, and that we're aware of any known allergies. And at the bottom, we have the vitals down there. And so we would collect those as from the historian as subjective information, or we would comment that the vitals were not able to be obtained. And then just like we would do on a regular note, we're going to have our assessment and plan section. So it's going to pretty much follow a traditional SOAP note. And then we've added areas for the more common things as far as lab ordered. Did we self-quarantine the patient? Now, something I didn't really add in this presentation is that it just came out that we can report or charge an E&M visit based on counseling the patient for COVID. So for rural health clinics, our problem is we still have to have a face-to-face with the provider. So if the patient is coming into our clinic following a telehealth visit to have a swab collection, we don't have another RHC encounter. But if we have a walk-in patient who comes into our clinic specifically asking to be tested, then if our provider will document the time spent counseling that patient on how they should self-quarantine, what the symptoms of the COVID virus are, other things that they need to know about limiting their exposure, and those kinds of things, then we can have an evaluation and management service based on time. So for 99212, that's going to be 10 minutes of counseling time. So our note also needs to has to have that time documented, and there has to be a statement that more than 50% of the visit was related to counseling the patient for COVID-19 prevention and exposure. Any questions before we go on? Still got a quiet group, huh?
No questions.
Okay. All right. I'm either doing a really good job or I'm doing a bad job. I don't know. So we have specific guidance for billing telehealth services for critical accesses and provider-based rural health clinics. There are unique modifiers that we're using. So if your business office or your coders or billers or your revenue cycle directors aren't aware of particularly how to use these new modifiers, reach out to me and I'll be glad to give you some examples. The DR modifier is only used by the hospitals. The CS, which denotes that the patient shouldn't have a cost share in that visit, can be used on any professional service. So the cost share goes on the evaluation and management, it goes on the professional service. And our 95 modifier indicates that the service was a telehealth service. So these are kind of new. The cost sharing, the CS modifier, there's been a lot of discussion about that. Does it absolutely have to result in a COVID test being ordered? And I think if we look at the intent behind what HHS and CMS were trying to do with the cost share modifier was they were trying to not prevent patients from seeking care if they thought that they had been exposed, So there are specific diagnosis codes, ICD-10 codes, to be used to indicate that the reason for the visit was a feared complaint of exposure or an actual exposure to the virus. So I think our clinical documentation just needs to make sure that that we're capturing that visit because the patient was concerned that they might have COVID, they might have been exposed to COVID, they weren't sure if they were exposed to COVID. I know as schools are starting back up and people are returning to the workplace from being at home, employers are requiring a COVID test to make sure, or a COVID antibody test to see if they already have recovered from the virus. And so we want to make sure the proper way to use these modifiers when we're reporting those services. And there are several ICD-10 codes, and there are ICD-10 coding guidelines that are out for reporting COVID-related episodes of care. I don't have those all included in this presentation, but again, you can reach out to me if you need additional guidance on how to use those diagnosis codes. And I just want to make sure that we know that our telehealth visits during the public health emergency do not have to be limited to just COVID-related concerns or diagnoses. So we want to continue to take care of our patients. We don't want them to not seek care because they're afraid to come into the clinic or the hospital emergency room or outpatient department. And so we can use telehealth to continue to take care of those patients. I really want to warn all of you. We had this come up yesterday with somebody who was saying they could do really quick finger stick COVID test, and they were selling them like 100 tests for, $500 or something like that. So beware of scams. Unfortunately, in our world, although most of us are well-intending good folk, there are people who will take advantage of the public health emergency and take advantage of patients and providers. So just be prudent if you're going to start using a new vendor who has lab supplies available or PPE available, and you're not familiar with that vendor. Make sure you do your homework, that you vet that vendor. Make sure they're reputable, get references from other hospitals, other clinics, other healthcare organizations that have used that vendor. You don't want to spend a lot of money and end up receiving inferior supplies or purchasing a test that has not been approved by the FDA for authorized emergency use. We're also seeing a lot of things pop up like remote patient monitoring, a lot of the retinal eye scans, a lot of things that are not separately reimbursed for the rural health clinic. So remote patient monitoring is not considered a billable service by the rural health clinic. It's considered part of chronic care management. We thought about this last year when the final rule came out, and we did not win. So, people are going to be trying to sell you things, which it's fine for you to buy those things. Just go in with your eyes open that may not be something that you're separately reimbursed for. As of yesterday, I checked, there are 6 point-of-care COVID testing equipment products that have been approved by the FDA for authorized emergency use status. Only 6 of them. So again, if somebody is trying to sell you a rapid COVID test, make sure it is on that approved list by the FDA. You will not be able to bill for those CLIA waived tests if they are not on that list. And be careful of vendors who are offering you something free. So maybe they're going to let you use their EHR telehealth module free for 90 days, but then somewhere in the fine print, there's a big hook that's going to lock you into something that you may not even be able to use after the public health emergency is over. So just, put your buyer beware hat on and make sure that, that you're not going to fall victim of a scam. Okay, so we've talked about the opportunities for telehealth during the public health emergency. We've talked about challenges. So where is all this leading us in the future? So I think that's the question that is in everybody's mind. So Secretary Azar, he's the head honcho at HHS. So a report was released a couple of weeks ago to show that Medicare providers and beneficiaries were rapidly embracing telehealth. So I believe it showed in April that there was over a 40% increase in the use of telehealth than prior to the public health emergency. And the report also showed that rural providers were lagging behind, primarily because of the challenges that we talked about. We weren't set up to do telehealth. We weren't able to ramp up and do it. Our organizations weren't quite nimble enough. So this is the link to the complete report that was released a couple of weeks ago. And it's very good. It gives utilization by telehealth. It comes from claims data. And so it's another indicator that we're probably not going backwards with telehealth after we're through with the public health emergency. Another thing that we want to talk about, and there's actually been no movement on this in the last 2.5 weeks or so, and that is there is a phase 4 relief effort of the Health Economic Assistance Liability Protection and Schools Act. It's called, like everything has an acronym. So this one is HEALS, which is going to sound like I say like small mountains, but it's HEALS Act. And so what it's going to do is I'm going to go back. It's going to continue the unemployment benefits. It's going to give individual taxpayers another stimulus check, and it's going to make some modest enhancements for rural health providers. So one thing that it's going to do is if the act passes, which is considered the phase 4 stimulus package, then the public health emergency will extend all the way till the end of the year. And it will also allow RHCs and FQHCs to be able to have a permanent fix for telehealth. So remember, we could not do distant site telehealth prior to public health emergency. So if we're going to continue to be able to provide telehealth from our rural health clinics and our FQHCs, then there has to be a change in the law. And this act would do that. It's also going to appropriate more money for rural health clinics and community health centers as part of this. So NRHA is calling this very modest improvements for rural health clinic providers. NRHA is of the opinion, NRHA and NARHC both have very strong advocacy, very strong lobbyists in Washington that are looking out for your best interest. NRHA is concerned that this act does not address the specific needs of critical access hospitals, and that if some of the provisions from the Hospital Preservation Act are not included, it is not going to be enough help to sustain our critical access hospitals across the country. So there's some good things in it. Right now, it's kind of sitting still. There hasn't been much discussion on it. Here's a little bit more information on that. I think I probably talked through this slide without having it up. And here's a great quote from Seema Verma, who is saying that now that we've let the telehealth genie out of the bottle, the genie's not going back in the bottle. So we need to be very, very active in advocacy to make sure that we're letting our federal representatives and congressmen know that we need permanent fixes for telehealth, and we need a payment model that is going to be sustainable for rural, since we are not going backwards from this. Part of the reason that there's been silence on the HEALS Act is that President Trump released his vision for the chart model, which is another payment transformation for rural. And so many people believe that this is a repackaging of older ACO and capitation models, and it appears to be more hospital focused than RHC focused. But very few details have come out about the chart model. It looks like it would be a pilot project between different agencies and a test group of hospitals to test this new model or this new methodology. So there's been a lot more press about the president's announcement last week than there has been about the phase 4 stimulus. But I wanted you to be aware of that. Again, if you're not actively involved in advocacy through NRHA or through the National Association of Rural Health Clinics, please get involved. You know, our congressmen, our senators, our representatives, they have a lot that they're trying to juggle right now, and sometimes they don't understand what your real concerns are. So please reach out to them and let your voice be heard for rural. You know, as we're doing this advocacy, we need to make sure that the reimbursement policy for telehealth is going to catch up to other public health initiatives. This always seems to be a problem. We have public health initiatives, we have population health initiatives, we have technology initiatives, and yet the reimbursement policy is slow to catch up to what we really want to be accomplishing for our patients and our communities. And it's only advocacy that's going to close that gap. And so even though we may get technology grants, we may be able to get equipment, we need to make sure that our professional and our facility reimbursement is going to parallel that we're not going to just get another room full of equipment that we really can't do anything with because we can't be paid for those services. And then we need to bridge the other barriers in telehealth, the communication barriers, connectivity issues, all of those barriers we need to close the gap on those. And patients come first, right? So the needs of our rural patients have to be met. That has to be number one. As much as we work in rural, as much as we travel across the country, the organizations who really do keep the patient first are the ones that seem to be more financially viable. And sometimes I can't explain that, except that if we keep the main thing, then if we're mission driven, what goes around is going to come around. And so we need to know how to collaborate to meet all these needs, take advantage of the resources that your state office of rural health has and these other organizations who have your best interest at heart. I think, Rhonda Ann, I'm to the end. Have we had any questions bubble up to the top?
Yes, we have one question, and then I have a few questions. But
okay.
Laura Potter says, I heard from one doctor friend that telehealth visits have been in some ways superior. Mother can show her their babies, the baby's environment. She says it's like being a visiting nurse, and she really likes it. Are there similar stories?
Yeah, there are some similar stories. There is a lot of evidence that telehealth services for behavioral health are actually more have better results. That if the patient that needs a mental health or a behavioral health service has less stigma attached to having that service provided by telehealth, or they're more comfortable being in their own home, not having to get out and be in front of people. And so, I mean, I think that's one of the reasons why Seema Verma says that the genie's not going back in the bottle, because in spite of the challenges, we've seen a lot of really good things happen with telehealth.
Okay, along that same line regarding behavioral health, are there many clinics that you know of that are providing group behavioral health visits?
That's a great question. So rural health clinics are normally rural health clinics are precluded from doing any group services. So remember, our definition of a rural health clinic encounter is a face-to-face encounter between the patient and the provider. Now, if you go back to the CMS list of approved telehealth services, group therapy codes are on that list. And so, you know, I think that we could probably do that during the public health emergency. My big concern is that we're going to get used to doing things a certain way. And if the public health emergency extends all the way to the end of the year, we're going to have had 3/4 of the year that we were operating under the exceptions instead of the rules. And so it's going to take a little bit of a transition time for us to get back and get guidance on how we're going to do business in the future. But normally in rural health clinics, we would not be able to have any kind of group sessions that were billable because of our encounter definition. But there are group therapy codes that are on that approved list and no restrictions to RHCs during the public health emergency.
Yeah, I thought that was just a great opportunity for clinics to be able to offer that.
Yeah, it's just, you know, and I think it's fine during this time. I think we're all concerned about, I'm concerned about my own mental health during this crazy time. So, you know, I think anything that we could do to support and stay in touch and give people, you know, affirmation and support is what we need to be doing right now. But going forward, we just may need to know that we won't be able to do those same services without the waivers in place.
Okay. Let me see. Since there is only one code the RHCs can use to bill telehealth, how can the clinics ensure that they are getting credit for preventative services, such as annual wellness visits or something along those lines?
So that is like the hot topic right now, because right now, since we only do use the G2025 for anything that's on that approved list, neither the patient is getting credit for that annual wellness visit in their common working file. And then if the provider is part of an ACO or some other quality group, they're not getting they're not having that service attributed to them either. So what some of us are recommending is, and this is not doable with everybody's computer systems, but you go ahead and record the service that you actually performed, and then you suppress it on the claim and only report the G2025 on the claim. And that way, internally, you know how many annual wellness visits you did. Also, the 95 modifier is an optional modifier right now after July 1st. So if you used that 95 modifier on that annual wellness visit, then internally you would at least have a tracking system of how many annual wellness visits that you did by telehealth. Now, not every system can do that. Not every system can record a charge and then suppress it on the claim. Sometimes that can be suppressed at the clearinghouse level if your own practice management or hospital system won't do that. But we can only report the one claim. But if we can internally capture how many annual wellness visits, CMS is aware of the problem. It's a problem for them also because that preventive service is not going on the patient's, on the beneficiary's common working file. So we won't know when their last annual wellness was or when their subsequent wellness is due. So it's a big issue, but you know, we have to, CMS has system limitations too. It's the whole reason we have the CG modifier. It's the whole reason why they create codes for us all the time is because there are limitations on their side as well. So it's a problem they're aware of. It's a problem that NARC is working on. And we just don't have a solution right now. So my suggestion would be if you can track that internally without those other codes falling on the claim, you would at least be able to support you know, to your ACO or, you know, somehow in the future, if we have a way to go back and correct that or submit extra information, we would have that internally.
Okay. Do you recommend to keep a log of the telehealth visits? And should the clinics, should they be performing time studies for the telehealth services so that they can be carved out?
Well, those are great questions. So we did early on, before people had EHR modules, we were suggesting keeping a log. I have a sample log that I would be be glad to share with you. The reason for knowing about how many services you did and capturing the time on those services is because for every telehealth service that we're reimbursed for in the rural health clinic, those costs are not going to be allowable cost because the payment that we're getting for that telehealth service is a fee-for-service payment. So yes, we're going to have some way to document, substantiate, reasonably estimate the provider time that was spent on telehealth medicine, because that's going to be coming out of our allowable cost on the cost report. So I would get with your cost report preparer, see what type of documentation they want, and see if your methodology, it doesn't have to be a super sophisticated way to keep up with it, but yes, we do need to be keeping up with it.
Okay, let's see. Laura says, this could be a dumb question. Has she seen broadband issues create issues across the country?
Yes, I mean, broadband and not having constant connectivity, or even not having not even having internet services. We think that there are areas that, surely everybody has internet, but we don't. So yes, broadband and connectivity issues are still probably one of our main hurdles for rural.
Okay. Well, we're at 1:01, so we should probably wrap it up. Thank you, Patty, for today's presentation. And thank you all for attending today's webinar. I really appreciate you all attending, and I'll be sending out a survey. If you would please complete it, that would be awesome. But thank you so much, Patty.
Oh, thank you for having me. Here's my email and cell phone number. If you have a follow-up question, just let me know. Thank you so much. Everybody have a great day.
Thank you, Patty.
Thanks,
Goodbye,
Rondine.
everyone.